Advanced Health and Physical Health Assessment, a recap from the Review and Resource Manual, Psychiatric Mental Health Nurse Practitioner, 4th edition, the Purple Book. Reasons to be familiar with a physical exam in psychiatry are to be able to detect underlying medical problems, be familiar with a screening neurological exam, and to be able to rule out neurological problems that may manifest as symptoms of a psychiatric problem, to be able to differentiate normal and abnormal signs and symptoms, and to know when to refer. The physical exam is done by the psychiatric mental health nurse practitioner in the context of her or his primary psychiatric care role. The goal of the exam are to identify the presence of psychiatric disorders, identify general health status, and screening for other non-psychiatric disorders. Focuses on physical assessment required to accomplish differential diagnosis and to determine the client's health needs. Specifically, it focuses on assessing for disorders or conditions that explain client presentation, such as psychiatric disorders and non-psychiatric disorders. It's not intended to replace the role of the primary healthcare provider for the client. The psychiatric mental health practitioner should assist the client to establish primary care if they don't already have primary care established. The PMHNP will also avoid personal and intrusive procedures such as pap smears, male genital exam, rectal exam, breast exam, that may make the formation of a therapeutic alliance more difficult, but it is important to be familiar with these exams and to be able to differentiate normal from abnormal. It requires the PMHNP to have depth of knowledge regarding the common health disorders that can mimic symptoms of a psychiatric disorder and formulate differential diagnostic criteria. It requires the PMHNP to have depth of knowledge regarding the common psychiatric disorders that can mimic or produce symptoms of other disorders, differential diagnostic considerations, comorbid considerations, and clinical management of these issues. Generally, if a client's health issues are determined to be non-psychiatric, the client is referred to primary care providers other than the PMHNP. Because of the brain-based nature of psychiatric disorders, the PMHNP role requires the ability to perform an in-depth neurological exam. The neurological exam components are reflexes, cranial nerves, coordination and fine motor skills, sensory functions, motor functions, and neurological soft signs. Reflexes are biceps, triceps, brachioradialis, patellar, Achilles, and plantar. Grade reflexes and note symmetry between the right and left sides. Check primitive reflexes in infants such as head lag, flexion, rooting, grasping, Moro, glabellar, and Babinski. A positive Babinski, which is fanning of the toes and dorsiflexion of the great toe, is normal in infants up to 2 years old. The cranial nerves: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, acoustic, glossopharyngeal, vagus, accessory spinal, and hypoglossal. The following section on the cranial nerves is from the Purple Book, but with my own adaptation and tricks for memory. Cranial nerve number 1 is the olfactory, and it's the sense of smell. I think of the olfactory cranial nerve number 1, and remember that we just have one nose for cranial nerve number 1. We test this through the sense of smell and ensuring patency of the nasal passages. Have the client close their eyes and touch each nostril, test each nostril separately while the other is occluded, asking the client to identify familiar odors. Cranial nerve number 2 is optic, 2 eyes. I associate the second cranial nerve with the number 2 because we have 2 eyes. Test the vision using the Snellen chart or other suitable chart depending on the client's acuity and ability to cooperate. Examine the inner aspects of the eyes with the ophthalmoscope and test peripheral vision using the confrontation test. This cranial nerve is often tested in conjunction with 4 and 6. Oculomotor is cranial nerve number 3. I randomly think about 3 motors. I'm not sure why. Oculomotor, and it's the third, so I think of 3 motors to remember this cranial nerve. This is the motor nerve to the 5 extrinsic eye muscles. Test together with cranial nerve number 4, which is trochlear, and cranial nerve number 6, which is abducens. Test the extraocular movements, that's EOMs, and check the equality of pupils, their reaction to light, and their ability to accommodate, PERLA. Test the corneal light reflex. When shining a light at the bridge of the nose, the light should appear symmetrically in both eyes. Cranial nerve number 4 is trochlear. I associate it with the word for spelled out, F-O-U-R. Use the same process as cranial nerve number 3 and cranial nerve number 6 abducens to test. Cranial nerve number 5 is trigeminal. I associate this cranial nerve with the word 5 because it kind of rhymes at the beginning. Tri and 5. Trigeminal, cranial nerve number 5. The motor division: palpate the masseter muscles with the fingertips while the client clenches his or her teeth. Look for disparity and tension between the two muscles, which can indicate paralysis on the weak side. Look for tremor on the lips, involuntary chewing movements, and spasms of the masticatory muscles. Trigeminal, cranial nerve number 5, sensory division. Test the tactile perception of the face by touching a cotton wisp to the face. Test the corneal reflex with a wisp of cotton. Test superficial pain of the skin and mucosa with pinpricks. And it tests the sense of touch in the oral mucosa. Cranial nerve number 6, abducens. I think of the number 6, abduce 6. I think about abducens as if it were abducix, and it just kind of rhymes. Use the same process as for cranial nerves number 3 and cranial nerves number 4, trochlear, to test. Cranial nerve number 7, facial. This is kind of random, but I think about 7 faces. 7 faces. To think about cranial nerve number 7, 7 faces. Inspect the face in response for evidence of flaccid paralysis. Test by asking the patient to elevate eyebrows, wrinkle forehead, close eyes, frown, smile, and puff cheeks. That's facial motor division. Facial sensory division, taste. Test for taste for sugar, vinegar, and salt. Cranial nerve number 8, acoustic. Also random, I think about 8 ears or 8 guitars, acoustic guitars. And that's how I remember cranial nerve number 8. Check hearing with the audiometer or by using the whisper test. Check for hearing loss using the Weber and the Rhine test. So you check for hearing using the audiometer through the whisper test, but we check for hearing loss using the Weber and the Rhine test. Cranial nerve number 9 is glossopharyngeal. For some reason, I think about glasses. I just changed the word a little bit instead of glossopharyngeal, and I think about 9 glasses. And that's how I remember cranial nerve number 9 being glossopharyngeal, 9 glasses, glossopharyngeal. Test together with the cranial nerve number 10, which is the vagus, by having the patient say, ah. Cranial nerve number 10, vagus. I don't have a fancy way to remember that, except I just do. Vagus is cranial nerve number 10. Test for elevation of the uvula by having the client open his or her mouth and say, ah. Test the gag reflex by touching the back of the throat with a tongue blade. Accessory spinal is cranial nerve number 11. I think about 11 spines to remember the accessory spinal muscle, or 11 shoulders. Test the strength of the sternocleidomastoid and trapezius muscles against resistance with your hands. Cranial nerve number 12 is hypoglossal. I just remember 12 hungry hippos or hippo tongues to remember hypoglossal cranial nerve number 12. Look for tremors and other involuntary movements when the client protrudes his or her tongue. Coordination and fine motor skills. Equilibrium, we check this by administering the Romberg test. So have the client stand up straight with feet together and arms by their sides when their eyes are closed. Only slight swaying would be normal, and the client will be able to sustain this pose for approximately 5 seconds. More than slight swaying suggests cerebellar ataxia or vestibular dysfunction. Diadokinesia is the ability to perform rapid alternating movements, such as patting knees, alternating palm and back of hands, touching thumb to each finger. The client should be able to smoothly execute these movements and maintain the rhythm. Sensory functions. For pain, we check sensation to pain with a pinprick and compare on each side of the body. Temperature, we check it by if the sensation to pain is abnormal. Superficial touch, test with a wisp of cotton. 2-point discrimination, apply pins to skin simultaneously and ask the client if he or she feels 1 or 2 pinpricks. Stereognosis is test the ability to distinguish forms by placing objects in the client's hands while their eyes are closed. The person's eyes are closed. Graphesthesia is test the ability to identify figures, letters, or words by tracing the figure on the skin of the palm of the hand. Motor functions. Muscle mass is measure the muscle mass to check for atrophy or hypertrophy. Muscle tone. Tension is present when the muscle is resting. Muscle strength is check muscular strength against resistance, and be aware of abnormal muscle movements. Neurological soft signs. Dysdiadokinesia is the inability to perform rapid alternating movements resulting from a lesion to the posterior lobe of the cerebellum. Asterognosis is the inability to discriminate between objects based on touch alone, and can result because of a lesion in the parietal lobe. Choreiform movements. There's tics. There's agraphesthesia, which is the inability to recognize letters or numbers drawn on the client's hand. There's facial grimacing, impaired fine motor skills, abnormal blinking, abnormal motor tone. Be alert for extrapyramidal symptoms such as in Parkinsonism, dystonia, akathisia in the client taking antipsychotic medication. Vital signs. Measure height, weight, blood pressure on children 2 years and older. On children under 2 years or older, you would also add the pulse, the respirations, temperature, and head circumference. I think the main point of that would be that infants younger than 2 years old, you check the head circumference. Use growth charts for infants and children. Greater than 85th percentile for body mass index places a child at increased risk for being overweight. Use BMI charts. The normal is 20 to 25, overweight 26 to 29, obese is 30 to 35. High BMI is a risk factor for diabetes, heart disease, stroke, hypertension, osteoporosis, and some forms of cancer. Be alert for high BMI if the client is also being prescribed psychotropic medication with a propensity for weight gain, especially with atypical antipsychotics. Head, skin, and nails. Note the color and integrity of the skin and whether there are lesions present. Assess skin turgor, temperature, moles, lesions, texture and distribution, capillary refill, clubbing, ankylosis. Examine the head and scalp and fontanelles if the patient is an infant. Examine the fontanelles if the patient is an infant. Check cranial nerve number 7, facial nerve, for symmetry. Have the client smile, frown, wrinkle the forehead, or puff cheeks. Be alert for Stevens-Johnson syndrome, which is a life-threatening rash, especially if the client is taking carbamazepine or lamotrigine, which is Lamictal. Cancerous moles can be detected by using the acronym ABCDE. A is for symmetry, B is for border irregularity, C is for color variation, D is for diameter greater than 6 millimeters, and E is for elevation. Eyes. Check visual acuity using the Snellen chart. It tests cranial nerve number 2, the optic nerve. Test peripheral vision using the confrontation test, and this is also cranial nerve number 2, 2 eyes, optic nerve. Note the symmetry of the eyes and the appearance of orbits, eyelids, and brows. Inspect the sclera. Assess corneal sensation with wisp of cotton. That would test cranial nerve number 5, trigeminal, and number 7, facial. Assess papillary reaction to light and accommodation, which tests cranial nerves number 3, 4, and 6. Assess the 6 cardinal fields of gaze, which are extraocular movements, test cranial nerve number 3, 4, and 6. Assess corneal light reflex. Light reflection should appear symmetrically in both pupils, and this tests cranial nerve 3, 4, and 6. Examine the inner aspect of the eyes with the ophthalmoscope. This tests cranial nerve number 2. So examining the inner aspect of the eye with the ophthalmoscope tests cranial nerve number 2. Be aware that many psychotropics can cause blurry vision, an anticholinergic side effect, and Seroquel may cause cataracts. Ears. Check for configuration, position, and alignment of auricles. Test auditory acuity through cranial nerve number 8. With a whisper test or an audiometer, inspect external auditory canals with otoscope for redness, swelling, or excess cerumen. Tympanic membrane should be translucent pearly gray without retractions or bulges. Nose and sinuses. Note the appearance of the external nose with note whether it is smooth, intact, symmetric, midline, has discharge, or is flaring. Assess nasal patency. Assess the sense of smell and inspect internal nasal cavity for patency and septal deviation. Palpate maxillary and frontal sinuses. For the neck, palpate the lymph nodes preocular, postocular, tonsillar, submandibular, submental, anterior, cervical for swelling or masses. Palpate thyroid, usually not palpable except in very thin people. Palpate and auscultate the carotid pulse and note any bruits. The back. Inspect skin and respiratory pattern on posterior chest. Palpate cervical, thoracic, lumbar, on sacral spine. Palpate the thoracic expansion. Percuss posterior chest for tympany. Auscultate posterior chest for vesicular or bronchovesicular sounds and note any adventitious breath sounds. Thorax and lungs. Assess respiratory rate and depth, regularity and ease of respirations. Note anterior-posterior diameter, which should be less than the transverse diameter. Percuss anterior chest for resonance and note the quality and symmetry of the percussion notes. Auscultate anterior chest for lung sounds. Normal breath sounds include vesicular over peripheral lung, bronchovesicular over the first and second intercostal spaces at the sternal border, and bronchial sounds over the trachea. All of those are normal breath sounds. And to repeat them again, vesicular over the peripheral lung, bronchovesicular over the first and second intercostal spaces at the sternal border, and bronchial over the trachea are all normal breath sounds. Inspect breasts in different positions with the client's arms relaxed and by the side, with the arms elevated above the head, and with the hands on hips, looking for dimpling, retraction, and orange peel-like appearance. Palpate the breast for lumps, including the tail of Spence. Palpate the axillary lymph nodes. Palpate subclavicular lymph nodes, also known as the sentinel or Virchow nodes. Be aware that typical, so that's first generation typical antipsychotics, as well as atypical second generation antipsychotics may both cause galactorrhea. As an added note, risperidol is a known offender of this side effect. The heart. Inspect, palpate, and auscultate the carotid pulse. Palpate peripheral pulses and check for symmetry. The peripheral pulses are the carotid, the brachial, radial, femoral, popliteal, pedal, and posterior tibial. Assess the heart rate, rhythm, amplitude, and contour. Assess anatomic location of the apical pulse. Palpate the precordium for pulsations, thrills, heaves, and lifts. Auscultate heart sounds with the bell and the diaphragm and note characteristics of the first and second heart sounds. Assess for jugular venous distension. Be alert for possible ECG changes if the client is taking tricyclic antidepressants or antipsychotics, and be aware that lithium and anorexia nervosa can cause peripheral edema. The abdomen. Inspect the contour of the abdomen and check for scars, abdominal aortic pulsations, and the umbilical cord in the newborn. Auscultate for bowel sounds and the abdominal aorta for bruits. Percuss the abdomen and note areas of tympany and dullness. It is normal to hear tympany over the small and large intestines and dullness over the organs or a distended bladder. Percuss the size of liver and spleen, and palpate the abdomen for masses and tenderness. Also palpate the liver and the spleen, which are not normally palpable. Sometimes the liver can be palpable in very thin clients. Musculoskeletal. Assess the client's posture for alignment of the extremities and spine for symmetry of body parts. Test muscle strength of upper and lower extremities. Note symmetry of muscle mass, tone, and strength. Assess active range of motion in the neck and the upper and lower extremities, and note any presence of pain with movement. Palpate muscles and joints to elicit pain, deformities, crepitus, and passive range of motion. Check for hip dysplasia in infants. Check for scoliosis in children and adolescents. Common indicators of physical child abuse are on the next slide. And they include the history of unexplained multiple fractures, burns, hand or bite marks, injuries at various stages of healing, and evidence of neglect, obviously, and bruising on padded parts of the body. Diagnostic and laboratory testing. Assessment of diagnostic and laboratory testing is an essential element for the PMHNP role. It is important for the PMHNP to know when to order such tests, how to interpret the findings, and how to appropriately alter care based on their findings. Reasons to assess diagnostic and laboratory testing in psychiatry. To assist in the establishment of a diagnosis as knowledge of underlying pathophysiology grows, diagnostic and laboratory testing use will grow as well. It's used to rule out other disorders such as medical causes of psychiatric symptoms. It's helpful in differential diagnostic assessment. And it is used to determine whether a client's symptoms are better explained by a non-psychiatric disorder or factors such as drug use or abuse. For routine ongoing monitoring such as general health screenings, monitoring drug levels of certain psychiatric meds, and assessment and monitoring for complications of psychiatric disorders or adverse effects of drugs. Thyroid function test. Function of the thyroid gland is to take iodine from the circulating blood, combine it with amino acid tyrosine, and convert it to the thyroid hormones T3 and T4. The thyroid gland also stores T3 and T4 until they are released into the bloodstream under the influence of the thyroid stimulating hormone TSH, which is released from the pituitary gland. Only a small amount of T3 and T4 are bound to protein. The free portion of the thyroid hormones is the true determinant of thyroid status. Free thyroxine T4 normal values are 0.8 to 2.8. The FT4 or free T4 composes a small portion of the total thyroxine and is available to the tissues and is the metabolically active form of this hormone. Free T4 or FT4 tests is commonly done to determine thyroid status and to rule out hypo or hyperthyroidism and to evaluate thyroid therapy. For increased diseases that usually can result in an increased thyroid level are Graves, thyrotoxicosis due to T4, Hashimoto's, and acute thyroiditis. Decreased thyroid levels are primary, secondary, and tertiary hypothyroidism, thyrotoxicosis due to T3, and renal failure, Cushing syndrome, and cirrhosis. And that's decreased thyroid levels, that's T4. And evident, and as we know, T4 and TSH, or T4 and T3 and TSH have inverse relationships with each other. Interfering factors are primary hypothyroidism is usually caused by autoimmune disorder. Secondary hypothyroidism is usually caused by pituitary insufficiency, and tertiary hypothyroidism is usually caused by hypothalamic failure. Some interfering factors that will cause the thyroid levels specifically T4, T3, to increase are heparin use, aspirin, and propranolol. And if you're medications that would cause a decrease in thyroid T4, T3 levels would be furosemide, which is Lasix, and methadone. A thyroid stimulating hormone, the values are 2 to 10. That's TSH. Stimulation of the thyroid gland by the TSH causes the release and distribution of stored thyroid hormones. When T4 and T3 are high, TSH secretion decreases. When T3 and T4 are low, TSH secretion increases. In primary hypothyroidism, TSH levels rise because of the low levels of the thyroid hormones. If the pituitary gland fails, TSH is not secreted and blood levels of TSH fall. TSH testing is commonly performed to establish the diagnosis of primary hypothyroidism. Diseases that have increased thyroid levels include primary thyroidism and thyroiditis. Diseases that have decreased thyroid levels include hyperthyroidism and secondary and tertiary hypothyroidism. Interfering factors or values can be decreased during treatment with T4, corticosteroids, and heparin. Comparing hypothyroidism with hyperthyroidism and what's common in both. This is my recap of what's in the book and does not include everything in the book. This is just what I thought was relevant or easy for me to remember. So for hypothyroidism, there's going to be fluid retention, and it's going to be the opposite for hyperthyroidism, which is excessive sweating. Hypothyroidism, they're going to gain weight but eat less. There's an inverse relationship there. And for hyperthyroidism, they're going to lose weight but eat more. For hypothyroidism, they're slow reflexes, clumsy, slow movements, slow speech, and slow thinking. For hyperthyroidism, it's going to be compulsive movements, restless, tremor of the eyelid. Hypothyroidism, memory loss and confusion. Hyperthyroidism, short attention span and labile emotions. Hypothyroidism is cold intolerance, and hyperthyroidism is heat intolerance. Hypothyroidism is sensory hearing disturbances. Hyperthyroidism is elevated upper eyelid, leading to decreased blinking. I missed a word there. It's elevated upper eyelid tremor, leading to a decreased blinking. And then hypothyroidism is cerebellar ataxia, loss of ECG amplitude, and for hyperthyroidism, it's dysrhythmias and tachycardia. This health assessment section was very busy and full of information, and so I decided to break it up into 2 parts. This concludes part 1.